Hello, my name's Steve McClave. I'm going to be the moderator of this symposium, and it's entitled Nutritional Experience in the ICU and Post-Discharge, Impact on Patient Care. The objectives for this symposium, we're going to look at the impact of volume-based feeding on a busy trauma ICU setting at a level 1 trauma center. I want to introduce a new up-and-comer that we're very excited about is Philip Prest. He's an associate professor of clinical surgery and a trauma doc at the University of South Carolina in Columbia. And he's going to talk to us about the experience they had in volume-based feeding and improving feeding in their level 1 trauma center. I'm going to start with some comments on big data and just kind of describe to you the level of evidence, these different types of studies, their positive points and their negative points. We currently live in a political, social, scientific environment in which we worry about fake news. We're constantly worried whether the information that's coming to us is accurate. And in a sense, as healthcare professionals, as scientists, we are seeking the truth. And what the heck does truth mean when we're talking about patient care? Well, John Ioannidis is an epidemiologist, and he says the truth of a research finding relates to its reproducibility by subsequent research trials. Or in other words, its positive predictive value. And probably the most important slide in the few comments that I'm going to make is shown here. And that is the range of positive predictive value for these different types of studies. At the very top are those large, huge randomized controlled trials. But the positive predictive value is not 100%. It's 0.85. That means 85% of the time, if we repeat this study, we would get the same results, or it would be supported by subsequent trials. It turns out a very well done meta-analysis of studies that have low bias and are good quality can approach that same positive predictive value of 0.85. But if it's a well-done meta-analysis, but the studies are not good quality, then the positive predictive value drops by half to 0.41. From there, when you go to the individual RCTs themselves, the smaller ones, epidemiologic, observational trials, expert opinion, the wheels fall off the bus. And now the positive predictive value is below 20%. Let's look at each one of these types and look at their positives and negatives. The value of observational trials is it lets us look at large databases or population epidemiologic studies. The problem is the majority, 5 out of 6, are going to be refuted within 10 years, according to this Ioannidis. And the problem is they suffer for the potential for confounding factors. And on this slide is shown what I consider to be a fatal confounding factor. This is a study from Yassine Arabi. He does great work. But in this study, he compared patients in the lowest tertile getting the least amount of feeding up to the highest quartile getting the most feeding. And as you can see, the more feeding they get, the worse the outcome. At the bottom is the readout for mortality, and it shows that the highest tertile getting the most feeding had twice the mortality as the lowest. Darren Hyland came back a year later, used the same methodology, and showed the same effect. The more feeding, the higher the mortality. And then he corrected for a single confounding factor, all oral days. When a patient on tube feeding advances to a tray and a diet, he's counted as having 0 enteral tube feeding calories. That means all the patients that are doing well move to the left of this diagram. If Darren adjusted for that confounding factor, look at the numbers. They reversed. And now the more feeding you get, the lower the mortality, not the higher mortality. This is a fatal confounding factor. Epidemiologic studies are also observational trials. And here you have to worry about true factors versus factors that have no relationship to what you're looking at. Look at the two pictures here at the top. On the left, if we had a large population of women like this that are outdoors exercising in the sun, and then on the right, we had a control group that was in nursing home, elderly, not getting outside, I would show you that vitamin D levels were lower in the population on the right. Well, a true factor would be exposure to sunlight. But say my own personal biases, I said, I think it's related to eating cold mashed potatoes. And I would show you that the group on the right, higher content intake of cold mashed potatoes, lower vitamin D levels. That's an example of a null field. I'm focused on mashed potatoes, but there's no relationship between that factor and vitamin D levels. And so the truth of an epidemiologic study is the ratio of true factors like exposure to sunlight are no relationship factors like cold mashed potatoes. Propensity scoring tends to improve on that. It would analyze and stratifying these covariants. It'd give a high score to the sunlight, a 0 or no score to the mashed potatoes. We have a time-honored practice of worshiping large randomized controlled trials, and there's a reason for that. It has the highest positive predictive value, which means that those findings should be the closest to the truth. And they do power analysis, so they are powered to show that effect. And they control covariance, confounding factors, co-interventions, and then we believe they have the lowest risk for bias. But that doesn't mean they're infallible. And here are several weaknesses that we'll show you. One is generalizability. Take the Panic trial of supplemental PN from Europe. It had great methodologic design, so its internal validity was great. But at the end of the trial, when we went to generalize the results, the external validity, it was poor because they gave this big slug of glucose, and they had tight glucose control that nobody else does. Assessment of harms is the fact that these randomized controlled trials are short in duration. Take Todd Rice's trophic versus full feedings. Those only lasted for 6 days. As a result, they could possibly miss a harm down the road, maybe a year later. And sure enough, in the single center trial he did first, the patients that got trophic feeding were more likely to go to a nursing home than their own home. Now, it didn't quite reach significance, and when they repeated the multi-center trial, they didn't see that fact. But that's an example where the 6-day randomized trial might have missed harm down the road. Multiplicity is the idea that if you ask or look for enough endpoints, one is bound to be positive. And the ratio is 1 out of 20 are going to be positive. But that's really a false positive. Perfect example is the Nephroprotect study by Doig. He had over 20 endpoints, and he had 4 different patient populations. That's over 80 endpoints. At the end of the trial, he had 1 positive finding, and it was creatinine clearance on day 3. Well, that really is multiplicity. That probably is a false positive. It was a negative study, but he didn't pitch it that way. And finally, greater flexibility is not a good thing from a validity standpoint. Research findings are less likely to be true with more flexibility. A perfect example there, pragmatic studies or real-world experiments, as I'll show you in a minute. Large randomized trials are not flawless, and that means that no study is so good that it supersedes all other trials. Obviously, the large randomized trials should get our attention and should help direct therapy more than others, but they're not infallible. Ioannidis says 10 to 15% of the largest randomized trials will be refuted. 25% of the smaller but still well-designed trials will be refuted by future studies. Some studies we have to worry about type 1 and type 2 errors. Type 1 error is that there's an early difference, but if you added enough more patients, that difference would disappear. A perfect example is the Arabi single-center trial in which he showed that underfeeding significantly reduced mortality. But when he came back and studied it again with 4 times more patients, that difference disappeared. A beta error is a thing that you don't see a difference early on, but if you kept entering enough patients, a difference would eventually emerge. Example here of a potential type 2 error is Eric Charles' trial of permissive underfeeding in trauma. He showed at the end of his trial that the trauma patients that got permissive underfeeding had the same outcome as full feeding. But his power analysis said he needed 116 patients. He only entered 80 patients. So you wonder if he had fulfilled the power analysis and entered more patients, if a difference would have appeared. Even if you have a large randomized trial of 1,000 or 2,000 or 4,000 patients, ironically, it could still be underpowered. Here's a slide that shows the mortality in the control group for 30 years of ARDSNet trial studies. This is that NIH study group that has done so much for our critical care in the United States. When they started 30 years ago, the mortality in the ICU was close to 70%. Now the mortality is below 20%. And that mortality is the event rate. And as that gets lower and lower, it gets harder and harder to show the benefit of your treatment. Your treatment might be trophic feeding or volume-based feeding or enteral feeding. And you're going to do a trial to show that that therapy lowers this mortality even further. That's called the delta rate. Well, the lower this event rate gets, the lower the delta rate. It means you need bigger and bigger and bigger trials. Also, if you did your power analysis 5 years ago and it took you 5 years to complete the study, well, the mortality rate now is half what it was when you designed the trial. And if the power analysis said you needed 1,000 patients, now at the end, you really need 2,000 or 4,000 patients. So even these large randomized trials may be underpowered. We love meta-analysis because it allows us to tease out a treatment effect from multiple smaller RCTs. And it gives you an idea of the strength of the literature at a glance. You can see by these confidence intervals, these horizontal lines, that they're either all in agreement or all in disagreement, and it gives you a feel at a glance. The grade classification that's been adopted by nearly every scientific society standardizes the quality of evidence for the individual study, but it gives us no recommendations at all for selection criteria. In other words, you're on your own whether to include or exclude studies in a meta-analysis, and that's a huge problem. And in one disturbing reference by LaLaurier, they had 12 instances where they did a meta-analysis and then came back and did a large subsequent RCT. 1/3 of the time, the subsequent large RCT reversed the findings of the previous meta-analysis. So that shakes our confidence a little bit. And now, real-world experience. This is kind of the new kid on the block in my mind. The definition of real-world experience is this is data we get day by day under normal conditions outside the confines of a randomized controlled trial. It's supposed to complement the randomized controlled trial and build on the generalizability of those trials. An example would be a survey or a tumor registry or a trauma registry, electronic health records, social media, insurance claims. There's great value in this data because it allows us to focus on, quote, real world experience and the general care that's delivered, not just the efficacy of a single treatment that we'd see in a randomized controlled trial. And it's cheap. It's a cost-effective way to evaluate safety, patient response, or economic issues. It can allow us to extrapolate data from a very tightly controlled randomized trial to other populations. Say the original trial excluded diabetics and patients with congestive heart failure. Well, you'd use real-world evidence to extend the findings to include those new populations. The flaws are threefold. The data can be all over the map. It can be very good or it can be very poor. There can be incomplete databases, holes in the database, and obviously there's going to be greater likelihood for bias. In an interesting report from Poland, the national government there was deciding what drugs to cover in their national healthcare program. They looked at real-world evidence, 89% of which were cohort studies, and experimental evidence, 97% were randomized controlled trials. Look at the high quality. The experimental evidence, the randomized control, that only 66% were considered high quality. And look at the real-world evidence, 50% were high quality. And when they went back to say what made us decide to cover the drug or not, 45% of the information came from real-world experience. And finally, in conclusion, remember the point of this is we learn the truth in science from all these forms of information. Remember that evidence-based medicine, only 1/3 of it is based on the quality of evidence in the literature. 1/3 is patient values and expectations, but 1/3 is our individual experience and expertise that we accumulate over time. There's a reason that the attending is ultimately responsible for patient care and not the first-year intern, which means that management treatment decisions should be based on the totality of information that comes to us, and we should consider all of them in the ways we manage our patients. And I'm going to finish there and go on to our next speaker. I'm thrilled to introduce Philip Press, and Phil's going to talk to us about nutrition in the surgical trauma ICU, why and how.
Thank you very much, Dr. McClave. Thank you for the introduction, and thank you for those brilliant words. Certainly very insightful. Brings me some pause about some of the data that I'm going to share with you shortly here, but I do think there's still a lot of value in it. As an aside, it's certainly very humbling and I'm very honored to be a part of this panel, and certainly hope and trust everyone is staying safe in this very difficult time. My portion of this talk is going to be focused on volume-based feeding within the surgical trauma ICU. Given the variety of folks who are talking today and the variety of environments that we all work in, I do think it's relevant to share just a few words about what kind of patients I treat and the environment that I work in. Prisma Health Richland is an ACS verified level 1 trauma center located in Columbia, South Carolina. It's the largest trauma center in the state, and it's smack dab in the middle of South Carolina. So it's getting patients referred from all directions to us at all hours of the day and night. We're also the major teaching university for the University of South Carolina. So we have a wonderful complement of residents, fellows, and students all contributing to the work that we do. Our patients come to us through an ICU. We have a brand new, beautiful, shiny 18-bed surgical trauma ICU. You can see we have a relatively young patient population with about 600 patients admitted directly there every year. This serves the basis of our patient population for the research that we do. Our patients are significantly injured. They are polytrauma patients in the most literal sense. They have injuries of every variety, heads and spines, lungs, everything is that you can think of is injured on them, very often all at the same time. Open abdomens, organ injuries, bony fractures. And you can see also that we have a very significant percentage of penetrating trauma injury patients, 15, 16% per year. To put it in perspective, that's about twice the national average. So Columbia is unfortunately a very violent town with a lot of patients coming our way. Trauma patients undergo a unique and certainly an incredible amount of stress. And that stress ultimately results in a significantly increased catabolic state, significant fluid requirements for our patients, which yields significant inflammation, leading eventually to capillary leak. A lot of what we do in the trauma world is spend our time fighting what's known as the lethal triad of death, or as Dr. Moore has dubbed it, the bloody vicious cycle. And here's roughly how it works. Until proven otherwise, all trauma patients are in hemorrhagic shock. They're all bleeding from some degree of an injury. That active hemorrhage does a couple things. The blood loss results in hypothermia, and the resultant acidosis, the metabolic acidosis that results from this, combines with the hypothermia to potentiate coagulopathy. The coagulopathy, of course, then recycles back and causes more active hemorrhage. This goes on and makes our patients incredibly ill. The way that we try to help our patients is to, of course, fight this as best we can. It's important to realize that with regards to infection, that trauma patients don't come in infected, that they arrive injured but otherwise healthy. And over the course of several days or weeks, we actually allow them to become infected. Central lines, Foley catheters, hardware that's left in place, dirty, open, contaminated wounds, these things become infected over time. And it's that degree of infection, that course of their hospitalization that causes them to be infected. So with this as our background, we set out a few years ago to see how we were nutritionally supporting our patients and how we could make any improvements in that. Our dietitian keeps a meticulous database so we could evaluate where we started and track our efforts along the way. So this is where we started. This was in 2011. And as you can see, it's really not very impressive. We didn't start our enteral nutrition until about day 4. We would reach our 80% of our nutritional goal day 9 at best, if ever, on average. Less than half the time we ever met our caloric needs or our protein needs. We didn't have any formal enteral nutrition protocol in place. We were using whole protein formulation with protein boluses. In short, we were doing it by sort of, a dealer's choice each and every day. Things changed. And so in seeing where we started, we really needed to set out a path of how to get to a better place. We needed to not be having delayed start times and variations in formulations. We were starting at such small areas and holding for procedures. We needed ways to get to a better and more stable place. And of course, the irony of this is that by 2009 already, we knew better. These guidelines had been out for a couple of years, and they supported early enteral nutrition. They had an emphasis on volume or on calories. And so we knew where we needed to go, but we didn't really know how to safely get there. So for the simple-minded surgeons among our crowd, to break this down like me, we needed to know really 3 things: when to feed, what to feed, and how much, and how to safely and effectively go about that. So when to feed. Well, we delayed long enough that by 2016, there were already other guidelines out from ASPEN, which supported the use of enteral nutrition over parenteral nutrition in all critically ill patients. And the early enteral nutrition was recommended to start within 24 to 48 hours. And of course, there was more emphasis on protein by this time than simple calories. There was good data behind this. McClave et al. Published a large meta-analysis of 21 randomized controlled trials, 13 of which specifically reported on infection. And you can see that both within infectious morbidity and overall mortality, there was a reduction with the early enteral nutrition. There were some reasons to suppose this to be the case. Overall, there was maintenance of gut integrity and, of course, modulation of stress and the reduction of the SIRS response. All of this, of course, independent of disease severity. I would highlight that modulating the stress or the reduction of the SIRS response is something that someone who spends his life trying to fight the lethal triad of death sounds very, very important. So this sounds like a very good thing. Moving on to what to feed, again, going back to the guidelines, both with regards to severe traumatically injured patients, as well as specifically traumatic brain injured patients, the recommendations were to use arginine with supplementation. So some degree of fish oil and omega-3s to enhance that arginine delivery. Again, there's evidence to support this. Drover et al. Had a large randomized controlled trial evaluating pre, peri, and postoperative use of arginine-supplemented immunonutrition on outcomes. And you can see that overall primary outcomes, there was an overall reduction in infectious complications. And with regards to secondary outcomes, there was a reduction of hospital length of stay. When looking at some various sub-analyses, we see that actually specifically, it's arginine that's supplemented with omega-3 nucleotides, which shows the big difference. And so it's really the interplay. It's the interplay of arginine, the omega-3 fatty acids, and the RNA nucleotides that help support the immune and vascular response to our significantly injured patients. Again, with regards to the lethal triad, this seems to make a lot of sense. So now the question is really how to go about delivering all this. How do we evaluate our patients for what their needs are, and how do we effectively and safely deliver what they actually need? Of course, we know that trauma patients are very high risk. They have high protein requirements and high caloric needs as well. Each and every day, we calculate the Penn State equation on all of our patients, and we have a very energetic and very supportive respiratory therapy department that allows us to calculate indirect calorimetry on our appropriate patients up to twice a week as standard and more if necessary. So we're able to get a lot of information on patients in terms of what actually our goals are going to be. And of course, despite the fact that patients are very high risk in the surgical trauma ICU, we also know that there's a lot of interesting and unique challenges to a surgical trauma ICU patient. These patients are going through multiple surgeries over the course of their hospitalization, which requires them to be NPO at midnight, many, many nights, sometimes many nights in a row. My favorite is the ortho add-on diet. These are the poor patients who have an injury that get added on by our brilliant orthopedic colleagues. It's supposed to be an 11 o'clock operation. A few more accidents happen. They're NPO. It gets pushed to 2 o'clock, 4 o'clock. The night team comes in. They can't handle it, so it gets pushed off the next day. And we find out at about 7 o'clock at night. So the patient gets a few hours of nutrition, possibly at a low rate, before being NPO at midnight, and the whole cycle starts all over again. Open abdomens, while not a strict contraindication to open feeding, we have to realize why their abdomens are open in the first place. Normally, they've undergone horrible catastrophe. Oftentimes, their GI tract is in discontinuity, or they're so hemodynamically unstable as to preclude their abdomens being closed. So these patients are often not able to be fed enterally. Of course, many of our patients have abdominal pathologies, gunshot wounds, blunt trauma to various parts of their abdomen requiring ileus, things that do not necessarily make them excellent candidates for aggressive enteral nutrition. And of course, many of them even just have gastric intolerance. Neurosurgical patients, traumatic brain injured patients often have intolerance to the GI tract, making feeding in this population even more difficult. So again, going to the guidelines, we needed to see what was easy to change and what we could institute without a whole lot of difficulty. Assessing the patient, we've already discussed. Initiating the enteral nutrition within 48 hours seems like a good idea. Taking steps to reduce risk of aspiration is a huge emphasis, of course, across the whole hospital. But what we really need are protocols within the ICU to make this happen. And what we need to more specifically address is our gastric residual volumes as part of routine care to monitor ICU patients on our enteral nutrition. In terms of looking at protocols, this is the one that we settled on, the Enhanced Protein Energy Provision via the Enteral Route Feeding Protocol, otherwise known as PEP UP, started by Dr. Hyland several years ago. This was the first major study that his group came up with. It was a smaller study, but it was really their first one. And they looked at a group of patients where they started semi-elemental peptide-based formulations. They started at 25 mL, added prokinetics and protein powder as necessary. And on day 2, they were able to get their rate up to their 24-hour target volume. Of note, they allowed a gastric residual threshold of about 300 mL, so more than some places were accustomed to. They did a larger multi-center trial a few years later, and they compared their PEP UP group to a control group. And what they found really mirror images of each other. They found that they were better able to deliver both calories as well as protein. This graph is adapted from that study. This is the one that's really looking at overall calories, but again, the calories and the protein ones mirror each other. And you can see a few different things from the 4 different curves there. Patients who were kept NPO, predictably, did not reach their calories much at all. Patients who were given trophic feeds eventually got to their caloric goals, but it took them a long, long time to get there. Patients who were given feeds and were progressed towards an hourly goal rate did eventually reach their goal nutrition as well. But you can see these peaks and valleys over the subsequent days. Peaks and valleys to me are very disconcerting. We really try to maintain a level of homeostasis in our patients, and stability comes from stability of all areas of their treatment plan. And trying to get them steady states is really important. And you see the steady state when you see the patients in green who were who were subjected to the PEP UP protocols. They got to their goal rate very quickly, and they maintained it almost perfectly evenly throughout their ICU course. Importantly, this important work by Dr. Hyland only included 4 trauma patients. And we see this throughout a lot of the nutrition literature. Because of those unique challenges to STICU patients, a lot of these larger trials do not have a lot of trauma patients included in them. And so now we were getting closer to where we needed to go. Between 2011 and present, we were no longer delaying start times or varying tube feed formulations. We were starting within 24 and 48 hours of stability. We were using a specific high protein semi-elemental immunonutrition formula, a supplemental arginine and omega-3 fatty acids and nucleotides. We started at 25 mLs per hour after stability on day 1 and increased straight to goal on day 2. There was no ramping up. There was no increasing. It was very, very clear. Go to goal on day 2. And we had a very formalized what to guideline for our nurses with a very specific gastric residual program. So this is what we actually did. This is the packets that we gave to our nurses. It highlighted the PEP UP protocol. We had, so we began this in August of 2013, and we really allowed 6 months of education between educating each and every nurse between days, nights, all of the PRN nurses, the nursing educators. The dietitian would participate in rounds to help explain it. And we surveyed folks along the way to make sure that we were all on the same page. The gastric residual program, or the gastric residual volume policy that we instituted was slightly more aggressive than what was initially proposed. The idea is that we really don't hold our tube feeds until there's either emesis or until a secondary sign of intolerance. Secondary sign of intolerance being either abdominal distension or abdominal pain. In this situations only do we check our gastric residual volume, and we only hold it if it's more than 500 mLs. If it's less than that, we decrease it if there's still signs of intolerance. Otherwise, we simply give it back to the patient and trial it again. So we're pretty aggressive. These are laminated and put at the bedside chart for all of the nurses to have. And so we did all this stuff to all of our patients, and we wanted to make sure that we were doing a good job at it. So we looked at a couple different things. This was really a feasibility pilot that we did after the first initial initial start of the program. This was looking specifically at 50 TBI patients really to see if we were making a difference and if it was safe. And if you remember back to the slides where this all began in 2011, this was a huge improvement. We were now getting goal to over half of our patients by day 3, and about 78% of our patients were meeting their protein and calories by day 5. So it seemed like we were going the right direction. We should continue the program and study it on a much larger scale, which is just what we did. So this was a larger retrospective review, which we recently published, and this was looking at a much larger number of patients, close to 500. And what we did was we took a large number and compared them to a historical cohort to make sure that we were, again, making progress and doing good for our patients. All of these patients were ordered a volume-based feeding protocol with immunonutrition containing arginine and omega-3 nucleotides and compared again to the historical cohort. And this is what we reported as our findings. You can see the pre-volume-based feeding category and the post-volume-based feeding category, and a lot of significant differences between them. The first was the injury severity score. All of our patients are pretty sick, but you can see that more recently, and in the post-VBF category, they're even more sick. Our blood glucose, we were able to have much and significantly lower episodes of hyperglycemia, and we were also able to have better glucose control overall. In terms of our energy and our protein needs, we were able to give statistically more protein as well as calories, or said again, we were able to have a much lower protein deficit in all of our patients. This is a way to look at the effects of our protein that we deliver to our patients. This is an effect plot, so all of these circles are an individual patient as time goes on in the ICU. So as time goes on up to day 30, you can see there's obviously less patients in the ICU. And what we see is that in the pre-volume-based feeding protocols, those patients really never catch up to their 80% goal. They never reach the degree of protein that is being delivered in our PEP UP or our volume-based feeding group. Surgeons are a little slow and need a little extra prodding, and so we like big numbers that are very easy to understand. So odds ratios are things that always catch our attention. And what we see in that our post-PEP UP group, the odds ratio of meeting our protein goal was nearly 12. Again, we saw nearly mirrored image for our caloric goals compared to our protein delivery. Here again is the effect plot of our volume-based feeding on calories. What we see here is that our pre-volume-based feeding category does eventually catch up to our post-PEP UP group, but it's not till after 30 days. So certainly after their most critical time in the ICU has been spent. It was important that we tease out the effects of gastric residual volumes on all of this. It might stand to reason that with less interruptions and less scheduled checks on our gastric residual feeds, that we might see more calories and more protein delivered. It turns out that that's not actually the case. If you look at our pre-PEP UP groups compared to our post-PEP UP GRV checks and our post-PEP UP no GRV checks, you can see that those two categories on the right are almost identical. In other words, it was not the GRV protocol that actually allowed us to deliver more protein and calories. It was the PEP UP protocol or the volume-based feeding protocol that allowed that to happen. The GRV checks help simplify things, and it helps streamline how we went about our delivery of enteral nutrition. And it certainly made life for our nursing staff easier in that there was less scheduled things to do. But it was not the variable that delivered the protein or the calories. Of course, nothing is really good if it's not safe. So we need to make sure that what we were doing is actually safe. And what we found was that it was actually very safe. In terms of our macro aspiration events, we actually saw less episodes in our post-volume-based feeding group. And in terms of emesis, there was slightly more emesis, but it was not statistically significant. The glycemic control, I think, is incredibly important. It's one thing to say to devise a protocol or a program that's going to deliver more protein and calories, design that carefully, implement it, and then get excited that we in fact deliver more protein and calories. That is something that we should expect. The question is really, what good is it doing our patients? There's so many variables within the ICU that sometimes variables are very hard to tease out in terms of what's actually happening with our patient population. But I think most would agree that glycemic control is a very useful surrogate for overall how well patients are doing. Patients tend to get hyperglycemic when things are going bad. It's not a question of controlling their glycemic index or their glucose with a glucose drip or a very aggressive insulin protocol. That's really not what it's about. It's about getting to the root of what's going on and making sure that that's the problem. So what we saw is that in our overall glycemic control, we had less episodes of hyperglycemia and less episodes of hypoglycemia. So our patients were overall better. And just as a final point, there was one more interesting side effect, is that our patients in the post-VBF group, actually more of them and a higher percentage carried a diagnosis of diabetes. So while you might have thought that the glycemic control should have been harder, it was actually easier and better controlled in the group. And again, I think hyperglycemia is an interesting and useful surrogate for overall how patients are doing. We know that when this is done poorly, patients do not do well. And again, it can be a marker of bad things to come. In terms of our secondary outcomes, there was really no significant changes in mechanical event days, length of stay, or hospital length of stay. But again, these were patients that were more sick, and so we might have expected them to fare worse, and that was not the case. As a final added bonus, we saw that TPN use actually went down. In our post-volume-based feeding group, we actually saw less patients and spending less days on TPN. This, by the way, in an era when TPN use seems to have increased throughout America. So our conclusion was that VBS with no gastric residual volume checks in a surgical trauma ICU is safe. It's more effective at the delivery of nutrients, including immunonutrients. It's preferentially effective at delivering protein, and overall improves glycemic control and decreases the use of TPN. So our suggestions are to feed early, use a well-tolerated and evidence-based semi-elemental immunonutrition formula, and really form a change team that has both strong physician leadership, a strong dietitian who's very willing to actively engage in the process, and a strong nursing leadership with a dedicated nursing staff capable and willing to perform all this. Thank you very much.
That was a great example of a sophisticated team taking information from the guidelines and from the literature, changing their practice and delivering optimal care to patients. It's an amazing experience that you shared with us. We burned up with questions from the audience, and I'm sorry we can't get to all of them, but I'm going to ask one question each to the speakers. Philip, on your presentation, we're focusing now on the phases of critical illness, and that early phases, we're worried about under-resuscitation, ischemic bowel. Do we suppress autophagy, mitochondrial dysfunction, glucose outpouring from the liver? Is it dangerous to jump to goal on the next day? Should we be cognizant of these phases? And the second part of this question is, where's the tip of your tube? Is it in the stomach or the small bowel, and does that make a difference?
Both fantastic questions. Thank you. I suppose I should have been more clear to assume that active and appropriate resuscitation happens. In our ICU, we do not feed if a lactic acid level is over 2 or if they are on Levophed or Levophed equivalents of over 12. So in generally speaking, that is improved by day 2. But yes, certainly in the throes of an active resuscitation, when folks are sick, when their mitochondria are screaming for oxygen, and when blood flow is being shunted away from the GI tract, that is not the time to inundate it with a whole bunch of enteral nutrition. So yes, we have to resuscitate and stabilize first. In terms of where the NG tube is placed, we are very aggressive at feeding the stomach. We do not feed post-pylorically, or I guess more appropriately or more specifically post-ligament of Treitz, unless we have documented evidence of intolerance. So we feed the stomach first and go from there.
Does any of this change whether the patient has evidence of refeeding syndrome, they're on pressors, they're on paralytic agents, or they're pediatric patients? These are all questions from the audience.
Sure. Paralytic patients, if they're on paralytics, no. Doesn't affect gut motility, so we're aggressive with that. Pediatrics, I can't speak to. We, in our trauma center, per adult ACS trauma guidelines, we feed and treat and take care of patients 15 and up. So our patient population is 15 and up because of the IRB. The study only included 18 and up.
And refeeding and pressors.
Refeeding and pressors. So pressors, I think I spoke to again. We try not to use a whole lot of them. Generally speaking, pressors can be a way of changing the red number on the screen for the sake of central oxygenation. So hopefully you don't need a whole lot of pressors in your trauma patients if you're resuscitating adequately with blood and stopping the major problem. In terms of refeeding syndrome, yes, we monitor our electrolytes aggressively. If our phosphorus drops, we are very aggressive at replacing it. If it drops below 1, we hold our enteral nutrition and replace until we're in a better range, and then start at a lower rate. So we are slightly more gentle if there's evidence of refeeding.
All right, that's great. We appreciate all these speakers. This was a fun symposium. Thanks for all your contributions, and we do need to close because we got to get ready for the next symposium.